Hello.
Hello. Hi, ma'am. Good evening.
Hi.
Uh, I have make you the co-host, ma'am. You can share the screen and start the class, ma'am.
Yeah. Just a moment. You
Okay.
made me co-host, no?
Yes, yes, ma'am.
Okay. Today Oracle host is not there. Only you are there. Something is wrong with this side.
No, ma'am. Name is visible only, ma'am.
Okay. 1 second.
Okay, ma'am.
Uh, it's loading. I don't know why. Hello. Can you hear me now?
Yes, ma'am. Yes, ma'am.
Okay. So I'm just checking where the polls and quizzes are.
Ma'am. Now, once you check it, ma'am.
Yeah, that's why I'm just checking before going in. So
Okay, ma'am.
untitled poll 2 has 8 questions. Poll 1 has 7 questions. Where does this finish? This when which of the following is strongly asbestosis? So asbestosis they have kept in both the polls. So I cannot start it after asbestosis also. Anyway, okay. I'll finish asbestosis and then only start the poll then. Fine, no problem. Can you see the video?
Yes, ma'am.
Okay. Okay, I'll start the class. Hello everyone, this is the second session of respiratory pathology and we're going to discuss very important topics and very important questions which are asked in your exam in respiratory pathology. This will be a rapid revision of all volatile facts, all high yield topics and the topics which are most expected in your exam. We're going to discuss long essay question and short essay question as well as a few short answer questions which are frequently asked in previous and few years back exams. Okay, not very old questions. In Oracles, we have recorded lectures, recorded classes, live classes, which cover in-depth topics, and we have practical sessions. There's an exam module also, and we have hard copy books also. So in recorded classes, it facilitates flexible learning. You can go ahead and rewind, and you can watch it as at increase the speed and watch it at your own convenience. Live classes, mostly in-depth topics we cover, and then in the live classes, there's going to be interactive polls and doubt clearance sessions also. There are express exam modules which have um, comprehensive coverage of syllabus with answer writing skills. There is a one-to-one doubt clearing session as well. Hard copy notes are also available for all topics. There's a question bank where you can go and solve questions after reading the topic and listening to lectures. Practical session will facilitate hands-on experience and also provide expert guidance. These are the subscription plans. So now we'll move on and discuss our respiratory pathology. We have long essay question. First, we are going to discuss a long case-based essay question. This is the first case for the day. A chronic smoker with history of exertional dyspnea. Okay, always whenever you read a case, always see that the case gives you lots of clues. So there is exertional dyspnea and weight loss. He died in a road accident, and the autopsy reveals voluminous lungs with rib markings on the surface. Okay, so we can see a few clues here. He is a chronic smoker. So we have to recall the conditions which is associated with chronic smoking. Okay, what are the conditions associated with chronic smoking? We have lung cancer, which is associated with chronic smoking, correct? And then we have chronic bronchitis. And then we have emphysema. So, lung cancer, chronic bronchitis, and emphysema. So, these are the conditions which are associated with chronic smoking most commonly. There are many more conditions, but these are the things which we have to remember. The patient had weight loss. Okay, weight loss somewhere correlates with lung cancer, correct? But look at what they say here. The autopsy revealed voluminous lung. That means the lung is enlarged in size more than normal, and there are rib markings on the surface of the lung. Okay, so what is the reason the lung is enlarged in size? So, in which condition the lung enlarges in size? Lung cancer, we have a mass, so the whole lung is not going to be enlarged. In emphysema, the lung is going to be voluminous and there is going to be rib markings. So, now we'll see. Now, what they have asked, they've asked diagnosis, types, and complications of this condition. Okay, so we have to see what is the diagnosis. The diagnosis here is emphysema, and in this case we are going to learn the types of emphysema. So what are the types of emphysema? We have centriacinar emphysema, panacinar emphysema, paraseptal emphysema, and irregular emphysema. So centriacinar emphysema, first of all we have to know what an acini is and how an acini looks like. So this is how a normal acinus looks like. So you can see here what is acini made of. Acini is made of a respiratory bronchiole and an alveolar duct, and then finally opens into the alveolus. So this is what an acini is made of: a respiratory bronchiole, alveolar duct, and then finally the alveolus. So we saw the types of emphysema. Centriacinar emphysema. Centriacinar emphysema has central dilatation. Okay, you can see the central part of acini is dilated. Pan-acinar emphysema. Pan, the word pan means whole or complete. So you can see pan-acinar emphysema, the whole acini is dilated. Okay. So centriacinar emphysema involves a respiratory bronchioles. Okay, it involves a respiratory bronchioles because this is the center part of this whole acinus. Involves a respiratory bronchiole, and this is the most common. This is common and involves in smokers. Panacinar emphysema involves entire acinus associated with alpha-1 antitrypsin deficiency. Remember, panacinar emphysema involves the entire acinus. As we saw, panacinar means complete or whole involvement. Paraseptal emphysema affects the distal parts of the acinus associated with spontaneous pneumothorax. So, what happens in paraseptal emphysema? It affects the distal part of the acini. This is the acinus. It affects the distal part of the acini. So when distal part of acinus is involved, there could be spontaneous pneumothorax. And then there is irregular emphysema, which is associated with scarring. So these are the types of emphysema. Now let's just discuss what is the pathophysiology of emphysema and why emphysema occurs. In chronic smokers, so we saw two causes of emphysema here. One is chronic smoking and second is alpha-1 antitrypsin deficiency, correct? So we have to see why emphysema occurs in these patients. Okay, so one alpha-1 antitrypsin deficiency, as you can recall, is a genetic condition. It is an enzyme deficiency and it is inherited in an autosomal recessive fashion, correct? So in these two conditions, what is going to happen is there is going to be damage, oxidative stress, and damage to the alveolar wall. Okay, alveolar wall damage. Alveolar wall has a protein which is known as protein. It is a protein lining. So alpha-1 antitrypsin deficiency. So this alveolar wall has a protease, okay, which holds the alveolus together and gives the elasticity to the alveolar wall. Okay, so antitrypsin, the function of this antitrypsin is a kind of protein. Okay, so this is an anti-protease enzyme, alpha-1 antitrypsin. So this stops from destroying the alveolar wall. Protease induced destruction, alpha-1 antitrypsin, stops the destruction of alveolar wall and maintains its elasticity. But once there is alpha-1 antitrypsin deficiency because of a genetic condition, what happens? Antitrypsin is not there, so proteases can come in and destroy this alveolar wall. So what happens to this alveolar wall? It becomes dilated and loses its elastic function to hold in air. The basic function of alveolus is to hold in air, right? So if that is gone, then it loses its elasticity, becomes dilated and loses its function. So that is the pathophysiology. Similarly, in chronic smoking, what happens is chronic oxidative stress leads to alveolar wall injury. So what are the complications of emphysema? First is cor pulmonale. Cor pulmonale is right-sided heart failure due to chronic lung disease. And then the second thing is pneumothorax. We saw that paraseptal emphysema involves the distal parts of the acinus, which can lead to spontaneous pneumothorax. So similarly, we can see pneumothorax because small blebs are formed at times. So this blebs can rupture spontaneously and result in pneumothorax. What is pneumothorax? Just a review for you. The lungs is here. The lungs are covered by what is known as pleura. Correct. So this is what pleura is. Usually pleura, there are two types of pleura, visceral pleura and parietal pleura. Visceral pleura is attached to the lung and parietal pleura is a little bit outside. So there's a gap here. So these blebs are formed around here and there is going to be rupture of these blebs. So there is going to be air inside the pleural cavity, which is known as pneumothorax. Okay, this is a very painful condition and this can cause respiratory distress. Pulmonary hypertension can also be a complication of emphysema. Increased pressure in the pulmonary arteries. Okay, because the lung volume is getting increased and there is increased venous return, pulmonary hypertension can happen. And then respiratory failure finally. Because the lungs, the air spaces are lost its elasticity, so air is going on and storing over there, right? Since the elasticity is lost, air is just going on and storing over there. The alveoli have lost the capacity to push air back, and this alveoli, which has what's the function of alveoli? It is gaseous exchange, right? So this gaseous exchange is not happening, and hence respiratory failure will happen at the later stages. So that is about emphysema. So we have done diagnosis, types and complications of emphysema. Also a little bit about pathophysiology of emphysema. So now bronchiectasis. Let's move on to bronchiectasis. This was also a short essay question which was asked in your exam. Bronchiectasis is a permanent dilatation of bronchi and bronchioles. It happens due to chronic infections. Histopathology of bronchiectasis, when we can see inflammation and destruction of the bronchial walls. Okay. So the most important cause is cystic fibrosis. Also, post-infectious conditions and also tuberculosis may cause bronchiectasis. Now, what are the clinical features? Because we know this is an infectious condition, there is chronic productive cough with foul-smelling sputum. And then there could be hemoptysis also. What is hemoptysis? Hemoptysis is nothing but blood-tinged sputum. Okay. So what are the complications of bronchiectasis? We have recurrent infections, respiratory failure, and also in later stages, abscess formation. So this is all small points about bronchiectasis. Now the next short answer question you have to know is co-workers pneumoconiosis. So what is co-workers pneumoconiosis? Co-workers pneumoconiosis results from inhalation of coal dust. The name itself says it. Co-workers pneumoconiosis is, so what is the pathophysiology? Now we have to know the pathophysiology of co-workers pneumoconiosis. So, okay, you have coal dust in the lungs. You have inhaled coal dust. So coal dust is going to get deposited in the lungs. Now, these coal dusts are foreign material. They'll be recognized as foreign material, and once any material is recognized as foreign, what is going to happen is our macrophages is going to come in and immune response is going to get triggered. Okay. Macrophages are going to come in over here. That monocytes, which are macrophages, they're going to come in here and they're going to try to phagocytose these foreign bodies. So when these macrophages repeatedly try to phagocytose these foreign bodies, but it's not happening, then they will trigger a massive inflammatory response which will lead to fibrosis. Okay, so when there is fibrosis, what will happen in this alveoli? We already saw that the lung has acini, alveoli, bronchioles, respiratory bronchioles, etc. So these are going to have massive fibrosis and scarring. So if an alveoli is there and there is massive fibrosis and scarring, what is going to happen in that alveoli? Again, there's going to be no gaseous exchange, which is the function of the alveoli. Okay. If there is no gaseous exchange in the alveoli, then again it's going to lead to respiratory failure. Same sequence: pulmonary hypertension, corpus nail, and respiratory failure. So that is the end point of co-workers pneumoconiosis or any condition which leads to fibrosis. Okay, remember that. Now, histopathology, you can show anthracotic pigment because these are all coal dust and coal pigments. So you can see darkly brownish black colored pigments in these cases. Okay, now we're going to see asbestos related disease, which is also very important question which has been asked. Asbestos leads to variety of lung condition. Asbestos is very dangerous. So first is asbestosis. Simple. Asbestosis is similarly like coal was a foreign body, asbestos is also a foreign body. When inhaling asbestos, it's going to get deposited in the lung. Correct? So these get deposited, but these have a very unique finding, the asbestos body. So these are asbestos bodies. You can see linear brownish colored materials over here with slightly beaded appearance. So these are asbestos bodies. Okay, just have a look. You can get an image also of this. So this is the asbestos body. And apart from this, pleural plaques. So you might have pleural plaques also in asbestos, a related injury. Most important is mesothelioma. Asbestos can result in a tumor which is known as mesothelioma. Mesothelioma is the tumor which arises from the pleura. We just discussed that there is lung and lung has an outer covering, a parietal pleura and a visceral pleura. So from the pleura, the tumor which arises is mesothelioma, and asbestosis is a very big risk factor for mesothelioma. So as we saw, we have in histopathology ferruginous bodies. Okay, ferruginous bodies are nothing but asbestos fibers. These are asbestos fibers which are coated with iron, and hence they are called ferruginous bodies. Ferrous is iron, as we all know. Correct. So fibrosis. We just discussed the mechanism of fibrosis. Asbestos is going to get deposited. It's going to be recognized as foreign, and then comes our macrophages. Our macrophages are going to come and try to phagocytose asbestos, and then they're going to trigger a massive inflammatory response, which will eventually lead to fibrosis. And can this cause respiratory failure? Yes, eventually. Again, the alveoli is getting fibrosed. And then gaseous exchange is being inhibited, and then this can lead to pulmonary hypertension, pulmonary, or even respiratory failure. Okay, So now, before moving on to pneumocystis carinii pneumonia, I want you to attend a few multiple choice questions over here. Okay. So let's just see a few multiple choice questions over here. Okay.
Ma'am,
Ah, yes.
class was done now, ma'am.
What? No,
Class
no,
was
no.
done now.
No, no, no.
Then why you have stopped, ma'am?
I'm just sharing the poll, no?
Acha, okay, ma'am.
Yeah, yeah.
Now you can launch it, ma'am.
Yeah, I've launched it. That's why I was waiting
Uh,
because there was this thing, no?
Acha, okay, ma'am.
Yeah, yeah. No problem. We can start again. I'll just start. You
Okay,
start
ma'am.
start the recording. I'll start with the next. Okay. So now we can move ahead and see pneumocystic carinii pneumonia. So pneumocystis carinii pneumonia is an opportunistic infection seen in immunocompromised patients, especially those with AIDS. The histopathology shows alveoli filled with foamy eosinophilic material. Okay. So these foamy eosinophilic material, what are these? These are nothing but macrophages which have phagocytosed our pneumocystis carinii over here. So they resemble eosinophilic material, foamy eosinophilic material inside the alveoli. What is the stain which has to be done? Komori methenamine silver stain. So this can highlight the cysts inside the macrophages. So what are the symptoms? Fever, non-productive cough, and dyspnea. Okay, so these are important symptoms which you have to remember. Remember, they are seen in AIDS patients. So that is most important, and also foamy eosinophilic material is present, and very important, Komori methenamine silver stain can be used to highlight cysts of pneumocystic carinii pneumonia. And then the next short answer question is differences between emphysema and chronic bronchitis. So the difference between emphysema and chronic bronchitis are emphysema is usually destruction of alveolar walls and loss of elastic recoil. We saw that alveolar walls are destroyed and there is loss of elastic recoil. But in chronic bronchitis, there is mucus hypersecretion, inflammation of bronchi. Okay, some major differences over here. In chronic bronchitis usually occurs in a little bit younger age, and emphysema usually occurs in a little bit older age. And then dyspnea is usually seen in emphysema at a very late and very severe stage, but in bronchitis can be seen at a very mild stage as well as very late stage also. So cough we know in bronchitis is copious, okay, copious sputum, but in emphysema sputum is very scanty. Infections are common in bronchitis, but they are occasional in emphysema. Respiratory insufficiency in bronchitis is very early, but respiratory insufficiency in emphysema happens at a very end stage. And then cor pulmonale is usually very common in bronchitis. We saw in emphysema also, it was there, but happens at a very end stage. Airway resistance is increased in bronchitis, while in emphysema, airway resistance is only slightly increased. Elastic recoil, as we already know, in bronchitis is normal, and in emphysema, elastic recoil is low. In chest radiograph, bronchitis shows prominent vessels and large heart size, but in emphysema, we can see hyperinflation, normal heart size. Okay, so these are the basic differences. Now, this is a very important question they keep on asking. So, this is the Reed index. What is Reed index? Reed index measures the thickness of mucus gland. Okay, relative to total thickness of the bronchial wall. I'll show an image over here for you. So, here you can see Reed index, a ratio of thickness of bronchial wall. Okay, the thickness of bronchial wall to the mucus gland. Okay, so you see mucus gland over here and then the bronchial wall. So here you can see, so this is the total thickness and then this is the thickness of the mucus gland. So this is what Reed index measures, the total thickness of the bronchial wall versus the thickness of the mucus gland. Now, this is just simple logic. You just see why Reed index is increasing. Okay, Reed index is normally 0.4 or less. Okay, why Reed index is normally 0.4 or less? Because the bronchial wall thickness, look at the bronchial wall thickness. The bronchial wall is very thick, right? And the mucus gland is only this much. So definitely when the bronchial wall is compared to the mucus gland, it is going to be very less. So normal is 0.4. But you can see in chronic bronchitis, what happens is the thickness of mucus glands increases very significantly. As we know, we have repeatedly seen that mucus glands are increased in chronic bronchitis, right? Because mucus secretions are increased because of smoking, more mucus production is necessary, mucus glands are increased in size, and hence thickness of mucus glands are also increased in chronic bronchitis. Because of that, what happens? The Reed index is increased in chronic bronchitis. This indicates chronic bronchitis. So remember, Reed index is normally 0.4 and in chronic bronchitis, the Reed index is more than 0.4 because of increase in thickness of the bronchial glands, as we can see here. So this is a chronic bronchitis where the level of A is also increased over here, and that is the reason why Reed index is more than 0.4. Okay. So before finishing the lecture, I want you to attend a few MCQs. Okay. So I'll just start a few MCQs over here. You try to attend them. So there are 8 questions. I'll give you a few seconds for you to go through them. And then we can finish the class. Okay, so I hope you were able to answer all these questions, and I think we have covered most of the commonly asked questions and also the short answer questions. Okay, so that's the end of today's lecture. Thank you so much.